look at two things with you that have kind of consumed my professional life. One is exceptional leadership, and you heard a lot about that this morning. I think we can all talk about management for as long as we want, but it's really leadership that's going to bring the troops along and make your organizations, your units, your facilities the very best they can be. And then the other thing is care management. And I talk about care management because in reality, if we don't manage care, we're not ever going to get to those exceptional outcomes. So that's my goal with you this afternoon. I also want to look at the link between the two, because I do think there's a link. And I think when I talk about care management, I'm talking about the broader piece of care management. I'm really not talking just about case management. Okay, so let's talk for a minute about exemplary leadership. I mentioned this morning that I am a longstanding member of the Organization of Nurse Leaders. We have, as part of our mission statement, exemplary patient outcomes, exemplary leadership, and how we support that as an organization. And what we've talked about, and what I've believed for a long time, is leaders might be born. How many of you think you were born leaders? I see a few brave hands going up. Come on, how many of you think you are naturally a good leader? If I put it that way. A few more hands are going up. Okay. But most of us, whether we're born as a good leader or not, most of us require some kind of coaching, some kind of education, some kind of mentoring. Would you agree? Yeah, so my mission with you is to get you thinking about that. I don't have a lot of answers. I have a lot of questions for you. The other thing that hit me as I was putting these slides together is identification and ongoing development of leaders is a major factor in succession. And I want you to take a look at succession. What's the first part of that word? Success. If you don't work towards success, you will not have succession. Do you agree? Don't you find that there are people waiting to go to your really exceptional patient care areas, whether you're inpatient, outpatient, OR, wherever, but you have to drag people kicking and screaming to those that don't have that same reputation? The other thing that I want to say to you, we heard a lot this morning about vision. Remember? Vision. I can see. Vision. I think the development of leaders at all stages means that you have a vision. And you will have a vision about your nursing department. You'll have a vision about your units. Joan Vitello, who I'm thinking I'm seeing over there, yes, does a fabulous session at the Organization of Nurse Leaders Leadership Academy on vision and how you look at an organization. I'm in this specific area talking about vision, about leadership development. And what is the development strategy, and what resources are you investing, and what is your plan? Because you heard this morning, I can dream, but without a plan, it's not going to go anywhere. Alternatively, if you don't have a dream, you won't have a plan. So they really do go side by side. Now, one of the things that I've done for part of my life is we've looked at something called most vulnerable units. Anybody have a sense of what I'm talking about? Almost every hospital I've ever been in has one. It's the one, and you can fill in your own blank. The physicians don't want to send the patients to that unit. You have a lot of turnover of staff. You have a lot of untoward incidents. You have higher readmission rates than you do in other places. Does this sound familiar? You have a lot of staff complaints. You have a lot of unrest. One of the things, and a colleague named Joan Russo and I did a lot of work around most vulnerable units, and we would actually go and spend some time on most vulnerable units. And while I don't ever want to say it's one cause, a lot of situations were related to the leader of the unit did not have knowledge about or skills in leadership. They had knowledge and skills about management. They could run a budget, they could do everything. But they weren't knowledgeable about leading their staff. And the other thing was they lacked a vision for patient care and staff evolution and how their staff would be developed. So how many of you, because I think I have a sense of this, how many of you have a most vulnerable unit in your hospital or your care? Okay, so here's my question. If you have one, what are you strategically doing about it? They do not go away by themselves. I can also tell you that just shifting the leader is not necessarily the answer. I've seen some heads nodding. You've had experience with this, haven't you? So I don't have an answer to it today, but I want you to be thinking about if you have a most vulnerable unit, if you own a most vulnerable unit yourself, what strategically can you do to begin to move it forward? And I think the keynote speaker this morning had a lot to say about that. Okay, so let's go back to exemplary leadership. What is your vision? Can you write down? You don't have to do it right now, but can you write down? Can you describe where you want your leadership team to be? And I don't care if you're a VP, I don't care if you are a director, a manager, a charge nurse. Everybody needs to have a vision for where they want their leadership staff to be. The leadership, if you're a charge nurse, may be the natural-born leaders or the whatever leaders that you work with on a daily basis. As I go higher in the organizational chart, I have higher expectations about formally establishing a strategy and a vision for how this is going to play out. How does this vision align with the goals and the vision of the organization and the department? Because if they're too much at odds, it's not going to play well. So they've got to be aligned. And what's the plan and structure to operationalize the vision, or visit, whatever? Let me give you an example. One organization that I worked with for a long time, we had annual goals that we developed for the department. Now, how many of you do that? Have an annual goal setting? Okay. We did that in November, early in November. In mid-November, we sat and said, okay, so what skills is the leadership team going to need to be able to accomplish those goals? What knowledge do they need? How are we going to get that to them? And then we set up a year's worth of seminars for our leadership staff. And they were mandatory seminars, and they were all sorts of things. When we were implementing clinical paths, for example, we had a lot of work around structured care methodologies. What does it mean? How does it work? Why would you do a clinical path? How do you have the discussion with physicians who say this is cookbook medicine? So it aligned with our goals for the department and the organization. The other question is leadership development incorporated into your budget? I see some of you shaking your heads, and I see some of you looking at me with great longing. Because your budget in many ways reflects what your priorities are. So if you're really prioritizing the development of staff and leaders, what is the infrastructure to be able to do that? Now, as we all do, I went on to Google. What did we do before Google, by the way? Or Wikipedia. I had no idea it was in Wikipedia. I love it. Maybe you all should look and see if you're in Wikipedia too. You never know. Okay, so this I found in Google, and I thought I would ask you, is this your organization? Spending on leadership development remains very high. As in prior years, the research shows that the number one area of spending is management and leadership at 48%. All our research on corporate talent shows that global leadership gaps continue to be the most pressing issues on the minds of business and HR leaders. How many of you are worried about succession planning? How many of you are worried about being able to recruit good leaders? Yes. This, I think, is going to be a huge issue for us in nursing. So, other questions for you. How are new leaders brought into the role? Not just this is the budget, this is your computer, this is your password, have fun. But strategically, who do they need to meet with? What skills do they need to have that they didn't necessarily bring with them? What is the organization's philosophy and beliefs around leadership? And how will they fit into that? How are your leaders assessed on an ongoing basis as a group? And again, whether you're a VP or a charge nurse, how are you looking at the needs for development of the leaders you work with? And then what are you doing to address the learning needs? This is a fabulous conference. It's a fabulous place to get education and knowledge. What, in addition to this, are you looking at? Okay, so now I'm going to switch a little bit because I do see a link between care management and leadership. So care management has always been essential. But in Cherry Ames' day, we all know who Cherry is now, right? Okay. In Cherry Ames' day, how long did patients stay? Forever. So we weren't looking at managing their care quite in the same way we are today. The other thing was Cherry worked probably 5 days a week, 8-hour shifts. So Cherry got to know her patients in a different way than we know now. But today's world is hugely different than Cherry's. Would you agree? Hugely different. So now we've got complexity of patients. How many of you believe that you've got the most complex patients in the world? Absolutely you do. And they're not just physically complicated. They're socially complicated, economically complicated, all those good things. So this requires strategic, exemplary leadership to make sure that you're looking at care management. And this is my definition of care management. It's deliberate, it's structured, and it's consistent. And it's a process to manage patient and family care, always as the dyad, within, throughout, and between each episode's trajectory in the continuum. So, how do we match needs and resources? Now that tends to be a case manager's job, but I really believe that staff nurses can do that too, at many, many different levels. It attends to managing clinical progression, and this is what I need staff nurses to do the most. The most. It is directed towards achieving exemplary outcomes. I believe that it's best achieved if you define accountability for who is going to do what in managing the patient's care. Now, my parents named me Kathleen A. They thought the A was for Anne, but it's really for accountability. They're stunned, but you know, they'll get over it. It also requires a constellation of roles. But staff have to have a role in this. It cannot be tossed over to case managers or social workers or whoever else is in the arena. Regrettably, this is what patients feel a lot while we're in the hospital, while they're in healthcare. Forget hospitals, it's how they get passed along. This is a picket fence. The only way a picket fence is going to stand upright is the horizontal bar. So my question to you is, in your organizations, whether you're inpatient, outpatient, home health, doesn't matter, who is the horizontal bar? This, I want to emphasize, is that the knowledge base of the nurses is critical to care management. That's why nurses are in such a good position to do care management, is because they've got that clinical knowledge that they need to bring. It's also a hugely satisfying role for staff. It's less mechanical and technical, and it's more relationship-based. It's more making sure that patients and families know what they need to know, can do what they need to do. All those things that we know. It's also, this patient is here today or on this visit. Why aren't they progressing? What do I know about the usual clinical progression of patients with this type of disease? Care management requires, I think, at least 3 things. Continuity of provider, harder and harder to get in today's kind of fractured world. Continuity of plan, and that's a huge one. And then continuity of information. And let me just give you a simple example. What information about the patient's plan is passed along as the patient moves from shift to shift, from site to site, from day to day? And I'm willing to bet that we can all use a little upping the ante on that one. So my business partner before I moved to emeritus status, Karen Zander, talks about the plan for the day, the plan for the stay. So who in your organization is accountable for management of the patient care at the day or shift or visit level? Who's accountable for the management of the patient across days and shifts within a geographic area? Who's accountable for the patient across units, across sites? Who's accountable for discharge planning and ensuring critical patient and family knowledge? And who's ensuring effective clinical and compliance outcomes for the patient and family and for the hospital? That's the plan for the pay. The last one I'll give you is case management. But we have to know that, a lot about that too. I talk with a lot of nurse managers, nurse directors about what it means to be a Medicare patient. And how many of you have read the book Medicare and You? About 3 of you. You can get it online. It tells you everything you need to know. It's from CMS. It's from the source. So it tells you everything you need to know about what the patient's responsibility is under Medicare and how much they're liable for. We are bankrupting patients. So if we look at these 2 things coming together, has the nurse's role in care management been defined and articulated? Is that in your role descriptions? If it's not, go back and look at them, please. I would ask you to do that. How is it aligned with your care delivery system? How many of you have a very clearly defined care delivery system? Okay, well, that would be a start. Look at your care delivery system, and in that, figure out how nurses are going to fit into that. How are staff educated to fulfill that role? What do your staff know about clinical progression, about pacing the case, about interacting with physicians who may not want to listen to them? How is it aligned with other care management roles, such as case managers or social workers? What infrastructure exists? Discharge planning rounds, care conferences, complex case conferences. And how are you evaluating the effectiveness? These are all questions that we have to keep taking a look at. When I look at creating both exemplary leadership and care management, one thing I know for sure: it cannot be left to chance. It has to be strategic. This is way too critical for patients in the organization, and we have to be paying attention to it. We have to develop approaches that are aligned so that care management, case management, all the other managements are coming together in a confluence so that it's strategic. If you have as a goal, how many of you, let me rephrase it as a question, how many of you have as a kind of goal that was sent to you to reduce length of stay? Okay, what's your strategy? How are you going to do that? The only way that I know how to do that is to do a better job of care management. So what are the mechanics that you're going to use for that? They have to be budgeted, they have to be consistent, and I think they should be evidence-based. There's a lot of evidence around these days about how to move patients along, about how to progress patients through different entities, about how to engage families and patients in their care, and how you provide the information that they need for that.